Hello, my dear friends. As the title of the video suggests, I am going to discuss the fundamentals of assessment of locomotor disability, especially in upper and lower limbs. All of you must be having a copy of this document, Gazette number 33004/99. This whole discussion is based on the statements, values, tables, and methodology found in this Gazette. Some parts are also based on previous Gazette and manual of 1981. The link to download this Gazette and other documents is given in attached description. This topic is not covered in usual orthopedic curriculum, but orthopedicians are required to give evidence in various courts of law regarding the disability of their patients and sometimes other unfortunate victims. Without understanding the basis of disability, you may find it difficult to face cross-examination. I face some problems, so I made this video. I plan to make you understand this topic so well that you will not forget it till the end of your practice. My goal is to make you a real expert with complete understanding of the fundamentals. Let us get the overall picture first. Overall picture consists of following 8 elements. If you understand and remember the keywords and concepts, you are done with the assessment of disability and you can face any cross-examination. Let us come to the definitions. Of all the definitions, first comes impairment, which causes functional limitation and which in turn causes disability. It's worth freezing your screen and try to memorize these functions as much as possible, or at least note the page numbers where they are found. If some pesky person asks you questions, you should be able to open the manual and read it out to him. Actually, special witness has a right to read passages from reference books in the court of law according to Indian Evidence Act. Medically, disability is physical impairment and inability to perform physical functions normally. Legally, disability is a permanent injury to the body for which the person should or should not be compensated. For example, paraplegic person may be totally and permanently physically impaired, but if he has potential to earn his living, his disability cannot be termed as total. That is given in manual page number 5. The job of the doctor is to assess the injured person and quantify physical impairment. Doctor may decide that paraplegia or impairment is permanent and total. Whether the person should or should not be compensated is the decision of the judiciary or executive. So, medical and legal disability are slightly different. Doctor gives the permanent physical impairment in percentages. Legal authorities decide the disability or compensation on the basis of this PPI. However, in this Gazette, the terms disability and PPI are used quite synonymously. Medical disability is related to physical functions. There are mathematical patterns in physical functions. You have to look for these patterns. You have to study these patterns to understand the assessment of disability. Then it becomes easy to remember, and we can use these patterns to express disability in the form of numbers. Let us take an historical example. This example shows how to convert a puzzle or problem into a mathematical expression. That is one page from Bhaskaracharya's book called Lilavati. In this page, you see his famous puzzle about a group of bees. He is challenging his beloved lovely daughter to solve the puzzle. The puzzle is aesthetically and poetically crafted in the form of a beautiful Sanskrit poem. After translation to English, the poem looks like this, where the Acharya is asking at the end, "Say, lovely woman, the number of bees." Gazette is like Bhaskaracharya's Lilavati. Only difference is Lilavati had puzzles in the form of beautiful Sanskrit poems, while Gazette has cryptic English statements. In this document, let us restrict ourselves as much as possible to the same words and phrases used in Gazette. However, we have to introduce new words and phrases to refer to numbers we derive in the intermediate steps in the process of calculation. Practically, direct determination of disability percentages is quite tricky or difficult. In clinical practice or medically, we measure disability quite indirectly. We do that by measuring the loss of physical functions. That type of measurement is reasonably accurate also. The value we get is physical impairment. When you make sure that the physical impairment you decided is permanent, it is medical disability. In short, medically disability is just PPI or permanent physical impairment. What court or authorities expect from you is to determine this same PPI in percentages, nothing less or nothing more. Let us look for the medical definition of disability. Medically, disability is physical impairment and inability to perform physical functions normally. That was given in Manual 1981, page number 4. In this statement, we can see the phrase physical impairment and inability to perform physical functions normally. It is nothing but functional loss. We also know that if a person has little functional loss, he has little PPI. If a person has more functional loss, he has more disability. So we can create a mathematical expression from this statement. PPI is directly proportional to functional loss or impairment. What does the court want? Court wants PPI in percentages. It doesn't want any mathematical expression. So both sides of the expression should be in percentage. What are the ranges on both sides of the expression? We know from the Gazette this statement. Total PPI should not exceed 100% in any case, which is repeated many times in Gazette. So 0 to 100% is the range on both sides of this directly proportional expression. If both sides of the expressions are directly proportional and both sides have the same range, then both sides should be equal. Then it becomes a mathematical rule. So you can convert mathematical rules into maths formula. PPI percentage is equal to I. Note the capital I. It is impairment percentage. It appears like a very simple linear equation. In words, it means like this. Disability or PPI is equal to physical impairment is equal to functional loss. Let us try to understand disability by the analysis of a typical case. Let us check if the formula PPI percentage is equal to I percentage can be applied in this case. In that process, let us also see what Gazette says about the various aspects of disability, and at the same time we can look for some mathematical pattern in these statements in Gazette. Let us assume a case of 1-year-old compound fracture of tibia and fibula due to high velocity RTA. Let us assume that you have relevant records of the case including the X-ray reports. You are an MBBS graduate, then you are good to go. Note that the idea is to assess the disability when the clinical recovery is complete. However, you have to know the diagnosis, date of injury, present status of fracture of tibia and fibula for the purpose of assessment and certification. In this case, the patient had open fracture tibia and fibula with bone loss. Patient underwent many surgeries. Presently, the tibial and fibular fractures are united. Let us see the clinical findings. This is a typical case. We come across such situations quite often. Of these 6 elements, the first 2, namely the active range of movement, strength of muscles, are easily measurable. All MBBS graduates have to learn the measurement of AROM and strength as part of their basic clinical examination. The activities like walking, squatting, sitting, cross-legged, etc. can be given points as ratios of normal and can be easily measured by inspection. You can see that these functions are measured in different units. Active range of movement is measured in degrees, strength of muscles is measured in grades, activities like gait are measured in ratios of normal. Similarly, if you look at other cases, you can see that sensation is measured in area, visual acuity is measured in ratios, hearing is measured in decibels, and so on. If we get a single method or unit to express all these losses, then it becomes easy to process the values mathematically. If we express the losses in percentages, it provides a common platform to compare and handle. Percentages can be expressed in smaller units also. It also becomes easy to equate with the disability, which is also has to be expressed in percentages. Actually, for some functions, Gazette gives direct percentage values for functional loss. One example is loss of sensation in hand, where Gazette gives direct percentages for different areas of the hand. At the end of the assessment of the loss of functions, you feel that all these percentages of loss of functions are easy to equate with disability. However, the 5th and 6th elements give some problems while understanding. They are the complications of the injury, of course, or these complications are produced by the same causative factor, and in this case it is injury by RTA. The 5th element, consisting of mild pain and chronic osteomyelitis, is not measurable easily. There is no doubt that these complications cause disability, but their effect on the functional loss or disability is not direct. they actually accentuate the functional loss, and that accentuation in turn causes more disability. These complications are not easily measurable. They are also difficult to convert into percentages. So they are not easy to equate with disability. Lastly, shortening is easy to measure in inches or centimeters, but its effect on the functional loss or disability is not direct, and conversion to percentages has little mathematical basis. You can note that the word complications is a term used in the Gazette and it's not coined by me. So broadly speaking, disability has two aspects: direct physical impairments and complications. You can see the difference between these two in this table. Let us look for some more examples. Loss of power in PPRP is physical impairment, and other examples of physical impairment are wrist drop, loss of opposition, loss of sensation, and complications or additional weightage or extra points. You can have examples like chronic osteomyelitis, shortening, neuroma, deformity, contractures, pain, etc. Earlier we knew PPI percentage is equal to I percentage or impairment percentage. After analyzing the last case, we know that some part of the functional loss or disability can be due to complications. Now we have to dismantle this original formula to include the complications. From the right side of this formula, we have to reduce some of the quantity of functional loss or I to accommodate or reserve values for complications. Even in the absence of complications also, we have to take the some part of functional loss. Rule should be same whether the patient has complications or not. The new mathematical formula looks something like this. PPI is equal to M into I percentage plus C or nil. Or nil means if there are no complications you can't take C. To use this formula for legal purpose, we have to know the ratios and the quantities. It should be same as given in the Gazette. On the right side of the equation, let us think that we know I percentage. We have to know how much of it is to be reduced by a fraction or a process called M. And we also have to know how much is C or complications in the unit of percentages. We can start from the complications and come backwards to know this how much aspect in this formula. Let us study the Gazette to know more about complications. Additional weightage is the specific term used in Gazette to name the complications in case of upper limb, and extra point is the specific term used in Gazette to name the complications in case of lower limb. We know complications are difficult to quantify. However, for clinicians it is quite easy to tell whether complications are present or absent in an all or none fashion. By eliciting tenderness, one can confirm if the physical pain is there or not. However, exact quantification is difficult. By seeing X-rays, orthopedicians or radiologists can easily say if there is osteomyelitis or non-union. All we need is a list of all the complications. In that list, we have to choose the relevant complications which are applicable in a given case or not. Then, Gazette being all-inclusive should be having such lists. Yes, it has. Let us study those lists a little later. For the time being, let us look in the Gazette to know how to further quantify the complications. Here is a statement, very important statement. You can see that extra points are percentages of impairment given in page number 70. This statement makes solving the problem quite easy. We noted that complications are not easily measurable like functional loss. However, now we know from Gazette that complications are percentages of impairment or functional loss, which is easy to measure. If you know the functional loss or impairment and know which complications are present in a given case, you can tell the contribution of complications to disability as a percentage of impairment. However, we just have to know what percentage should be given to which complication. Before going any further, I would like to tell what I am planning to do. I am just demonstrating the maths behind the statements in Gazette. It is just to make sure that you remember the statements and the connection between the statements. I am not explaining any why of the statements. I am just showing how they are connected. In that way, we get the overall and broad picture about the assessment of disability. Let us make a regular arithmetic formula to represent our progress till this stage. PPI is equal to processed functional loss. That's what I told you. Functional loss has to be reduced to make way for complications. Plus processed complications if present as percentage of functional loss. This is very important. Complications are percentages of functional loss. Symbolically, PPI is equal to M into I plus N into I. We know I or physical impairment or functional loss. Only thing we don't know till now is M and N. How much is M or what is the process of M, and how much is N or what is the process to get N is all that you need to solve this puzzle. In mathematics, when a problem is intangible or not solvable, we use axioms and postulates. They are the mathematical truths which are accepted without proof. Let us check the axioms or rules to quantify the complications in gazette. Of course, there is no proof. What is the maximum percentage you can take out of the functional loss and assign that for complications? That is the question. In case of upper limb in page number 69, it is given a total of up to 10% additional weightage can be given. And in case of lower limb in page number 70, it's given maximum extra points for associated problems like deformity, pain, contracture, etc. to be added are 10%, excluding shortening, of course. In cases of shortening, maximum extra points are not limited. But indeed, the extra points due to shortening are also in percentages of the functional loss only. So in above statements, we have a whole limit and a part limit. The whole limit is 100%. The part limit is contribution of complications to disability. It should not exceed 10%. Naturally, next comes the remainder of the functional loss. We have taken out 10%. What is remaining? It should be 90%. After reserving 10% for the complications, the remaining functional loss which causes disability has to be only 90% of the original functional loss. These statements just we studied also mean even if the functional loss is 100%, only 90% of it can be taken for disability. Do you remember the original equation? It was PPA percentage is equal to functional loss percentage. It was a linear equation with a range of 0 to 100%. Suppose there is a case with 50% functional loss and complication, what happens? In the previous case with 100% functional loss, we took only 90% as the cause of disability and reserved remaining 10% for complications. Now in this case of 50% functional loss also, you should take the same proportion of functional loss or 90% of functional loss. That comes to 45% as the cause of PPA. Remaining 5% of PPA is to be reserved for complications if present. So in the case of 50% disability, 45% is due to functional loss and 5% is due to complications if present. If there are no complications, what happens to the reserved functional loss? That is not considered, of course. That is, if there are no complications, you can take only 45% PPA. You should neglect remaining 5% PPA. Now we know something very valuable. In cases of 100% permanent physical impairment, you have 100% functional loss. There is no doubt. Out of this 100% functional loss, 10% can be due to complications. Note the term can be due to complications. Remaining 90% of functional loss is the producer of direct disability. Symbolically, at 100% disability or 100% physical impairment, that mathematical rule appears like this. Now we know M is 90 and N is 10. That is, we are sure. After substitution of M and N with 90 and 10 respectively, the formula looks like this. At 100% disability or 100% physical impairment, same formula in words looks like this. PPA percentage at 100% is equal to 90% of functional loss and 10% of complications. So we have a ratio of 90:10 between the elements on the right side of the equation when disability is 100%. This is a linear equation, so same ratio should apply to all values in the range, and also you can remove the common denominator because it is a linear equation. Let us remove the common denominator of 100. Let us remove percentage and replace with ratios. So PPA is equal to 0.9 into I plus 0.1 into I. Before jumping in happiness that we have solved the puzzle, let us confirm that we have some more evidence. There is one more place showing this rule slightly in a different tone. You can find the following statement in Gazette of 2001 in page number 19 of 68. The extra points should not exceed 10% of total ARM component and total PPI should not exceed 100% in any case. That's a beautiful statement. It solves many of our problems. It means in a case of 100% disability or 100% PPI, the complications can be of maximum 10% of the total impairment. Number one. So 90% of the disability is due to direct function loss and 10% of disability can be due to functional loss due to complications. Or in other words, the first point is 100% functional loss on processing should end up in a value of 90% and not more than that. So we should have a mechanism to limit the functional loss to 90% of the original, whatever may be the functional loss. Secondly, even in a case of 100% functional loss, whatever may be the quantity of complications, it should get limited to a value of 10%. We should have a mechanism to see that the complications get limited to 10% of functional loss. Now, after knowing this ratio, let us look for more rules in Gazette which can help us to understand how to further quantify those intangible complications. I told you about the lists of complications in Gazette before. Let us see the lists in detail now. Following table from Gazette 2018 describes a list of complications for upper limb. Additional weightage is the term specifically used in Gazette to name the complications in case of upper limb. And this is the list for lower limb. Extra points is the specific term used in Gazette to name the complications in case of lower limb. Just notice the first sentence of this slide. It says extra points are percentages of impairment. In these tables, what you see is a list of complications and percentages. Actually, what are these percentages? That takes us back to the first concept we listed in the beginning. Just now I mentioned complications are percentages of impairment. We know that the said rule was given in Gazette 2018 in the section on lower limb at page number 70. That's what we saw in the previous slide, and you can see that in this slide also. Extra points or percentages of impairment are given for deformities, pain, contracture, etc. Mathematically, we get a clue in this sentence. So extra points are actually percentages of impairment. Hence the phrase extra points refer to additional weightage or accompanying factor or simply complications. This is a very important concept that makes the job of quantification of complications easy and complete. Clinically, orthopedicians can easily find whether the victim has any complications or not. Orthopedicians also can easily measure the functional loss in percentages. Just we have to calculate the complications as percentage of functional loss. In a person with 100% disability, extra points can manifest into same percentage of disability as given in the list, subject to some conditions. For example, if there is a complication of 9% value, that means in a case of 100% impairment or functional loss, presence of that complication is responsible for 9% disability. So the values given in percentages in those lists are the manifested values or extent of complication in cases of 100% impairment. If the impairment is less than 100%, you have to take proportional percentages or proportional values, because as I told you already, we are dealing with a linear equation and the complications are percentages of functional loss. For example, if the functional loss is 50%, the same complication which had 9% in the list, in that case is capable of causing 4.5% disability only. The reason is we are dealing with a linear equation and the same ratios are to be maintained. Whether it is 100% or 50% or 70% impairment, you have to take the same percentage of the total impairment. Now we know so many rules, axioms and postulates regarding the relation between the complications and disability. We are ready to find a practical approach to handle the complications. Only thing is, the approach should be exactly what is given in Gazette. Let us use an example to understand this not so obvious process of Gazette while building an easy approach to it. let us have an imaginary case with a functional loss of 60% with mild pain as complication. How to assess the medical disability in this case? First of all, we have to find the percentage of functional loss and process it so that it shall not exceed 90%. Though it appears easy, it is quite a long process. We will go through those steps soon after this discussion. So in this example, 90% of 60% is taken, that will be 54%. Then we have to deal with the complications. In the previous slides, we saw the lists of complications in Gazette. For this case, we have to see which of these complications are applicable in an all or none basis. That is quite easy. Let us note them and the percentages assigned to them. Let us make a total of these percentages of eligible complications in percentages and call that value as total eligible complications or TELC. This step is same irrespective of the quantity of functional loss in any case. This is the first step in the processing of complications. In this example case, mild pain is found in the list. It is assigned 3%. This patient has none of the remaining complications, so TELC or total eligible complications in this case is 3%. Next, we have to take that much percentage of the present functional loss. The quantity we get is the extent of complications or manifested percentage of complications. Let us call that value as extent or quantity of complication or EXC. That is the second step in the processing of complications. In this example case, the functional loss is 60%, 3% of it is EXC or 1.8% is the EXC. Whole of this EXC cannot be taken for PPI in cases with lot of complications. We have to process these manifested complications by applying the limit of 10% of the functional loss. Let us call it as allowed limit of complications or ALC. We have to compare EXC and ALC and take the lower value. That means you can take up to 10% of functional loss as complications. That is the third and the final step in the processing of complications. ALC in this case is 10% of 60% or 6%. We have to take the lower value among EXC and ALC. In this case, we have to take the lower value among 6% and 1.8%. That would be 1.8%. Add the processed complications to the processed functional loss. That's how you get PPI. Final disability will be 54% plus 1.8% or 55.8% is the total PPI in this case. Let's see one more example. How to handle the same complication of mild pain in a case of 100% functional loss. First, 100% functional loss gets trimmed to 90% to summary functional loss. Then TLC is 3% as in the previous case. Next is EXC. Extent of complication is 3% of 100% or 3%. So, in cases with 100% functional loss, both the EXC and TELC are same. Next, calculate ALC. ALC is 10% of 100% or 10%. We have to take the lowest value among 10% and 3% and that would be 3%. Final PPI will be 90% plus 3% is equal to 93%. In the Gazette, only the presence or absence of complications is important. In fact, only the assigned percentages of complications which are present in that case is important. That will give TLC. The quantity of percentages manifested due to the complications depends on the functional loss. That means as functional loss increases, the extent of complications also should increase. And the highest quantity of complications that we can take also depends on the functional loss. That means as functional loss increases, the value reserved for complications also should increase. Or in other words, both the quantity and extent by which the complications cause disability depends on the functional loss. Finally, mathematically, complications are a function of functional loss. The corollary is, if there is no functional loss, no complications can be considered or allowed. Let us summarize our mathematical statements. On the left side, we have statements from gazettes and the manual, and in the right column, we have mathematical expressions and equations. I am just showing the background steps of calculation in Gazette, showing the relations and ratios between the elements. On the left side in the Gazette we had this definitions of locomotor disability and medical disability, and from that we derived a relational expression. PPA percentage is directly proportional to capital I percentage. Total disability will not exceed 100%. That has been mentioned many times in the Gazette. So both sides are proportional and both sides have the same range, 0 to 100%. That means we can remove the proportional sign and put equal sign. Then comes this statement on additional weightage. Up to 10% you can put. So that means we have to take 10% out of the physical functional loss and reserve that for complications. So symbolically PPA percentage is equal to M into I percentage plus C, maximum is 10%. Next comes extra points or percentages of impairment. So C is also a function of I percent. So we represent that with N into I percentage. See, M and N are either constants or processes. At 100% of disability, we know up to 10% of additional weightage can be given. So N becomes 10. So what is left is 90. PPI percentage at 100% of disability is 90% of I plus 10% of I. So in case of complications, we have to find the minimum between EXC and ELC. The extent of complications is calculated by multiplying the total eligible complications into functional loss, and ELC is calculated as 10% of functional loss. You take the minimum of EXC and ALC. In this way, Gazette simplifies the assessment of medical disability. While doing clinical examination itself, you will be calculating the functional loss and the summary functional loss in a step-by-step process given in the Gazette. Then you process the complications in 3 steps which we have already discussed. What you get is processed complications. Add both the processed values to get the PPA. Thus the assessment of disability becomes quite easy to manage. What we have been seeing is a single dimensional function loss. In practice, the functional loss will be in more than one dimensions or category. We shall come to that aspect in the next part of the discussion. So in practice, the decimal 0.9 or 90% is not used simply like that. Actually that 90% represents a set of processes the functional loss undergoes to get reduced to 90% when the functional loss is 100%. So here is a symbolic representation. We take the functional loss, reduce it to 90%, put it from this part of the machine, and take the complications, maximum 10% you can take, put it from this part of the machine. The machine is Gazette 2018. दूसरा side से निकलेगा PPI or medical disability. Why was it designed like this in 90% and 10% ratio? Gazette says nothing obvious about that. Obviously Gazette is not a textbook, it is like a manual. It gives only how, it never explains why. We can take a guess, probably because of the following reasons. First, 90% of impairment causes most of the disability, and at the fag end of the functional loss, much of the disability is not caused by the last 10%. So that was reserved for complications. Second is to prevent exaggeration of complications as the cause of final impairment. If you set a limit, people will not cross that limit. Third is to offset the errors of clinical judgment. Fourth, maybe to reduce the effect of malingering. Do you have any more clues on how much importance should be given to loss of function and how much importance for complications? Let us go further in Gazette 2018 and check for more clues to support this rule. Just look at this following table. It is based on table number 5.2 in upper limb amputations. Let us consider a case of little finger amputation through MP joint. After looking at this table, previously discussed rule appears quite reasonable. Otherwise, by adding dominant hand 10% and contracture of 9% and severe pain 9%, that is total of 28% complications to little finger amputation, you can give 30% disability. Then the disability becomes equal to disability of a person with thumb amputation. That looks absurd. Similarly, consider a case of just thumb amputation. It has a disability of 30%. It is not eligible for disability allowance. But the case can be made eligible for allowance just by adding 10% additional weightage of dominant hand. It is not correct. Actually, additional weightage means add extra percentage of impairment additionally as a percentage of impairment. Now let us move on to processing of functional loss. Note, the aim is to trim the functional loss to a maximum value of 90% even in a case of 100% disability, and never ever more than that. That resultant value is called summary value in Gazette. To make it easy to remember, let us call that value as summary functional loss. Functional loss has to undergo three processes to get converted to summary functional loss. It represents the direct permanent physical impairment. If the complications are present, we have already discussed that they represent indirect permanent physical impairment. Also note that the functional loss is also approximately called impairment in Gazette in this whole process. The main idea of processing functional loss is to limit the final value to 90% even when the total functional loss is 100%. First process is to convert functional loss which are in different units into percentages and then to mean percentage loss. Let us see how it is done. For example, if a PPRP patient has only 5 degrees of active extension of right hip, what is the disability with respect to right hip without considering the loss of muscle strength? For reference, normal hip extension is 0 to 15 degree given in appendix 3 page number 110. First find the loss. Normal is 15 degree, present value is 5 degree, so the loss is 10 degrees. Convert that loss to percentage loss. We have already discussed why losses in degrees should be converted to percentage loss. Here is the formula. Percentage loss is equal to quantity of loss divided by quantity of normal into 100. The solution looks like this. We get a value of 66.67%. Does that mean that the patient is disabled to the extent of 66.66% with respect to right hip? Wait, something is wrong. Common sense says that just loss of some abduction should not cause that much of disability. Let us take one more case. Suppose there is another PPRP patient who has involvement in both hips, a bilateral case. Say this second patient has similar gluteus maximus weakness in both hips. In addition, his left hip also has gluteus medius weakness, so resulting in decreased abduction in his left hip. What is the functional loss? On the right side, we have already calculated it is 66.67%. On the left side, 66.67% loss of extension plus 33.33% loss of abduction. Of course, this second patient must be having more functional loss because of bilateral involvement and involvement of two groups of muscles on the left side. Let us see on the left side what is the total. It is 100%. This patient is affected to the extent of 100% with respect to his left hip. Well, it can't be. You can see that many functions are not at all affected, represented by zeros. Then what did we forget in the first case and in the second case? We forgot to calculate the mean percentage loss. Hip has 6 active range of motion directions, not just 1 or 2. So we have to divide the total by 6 to find the mean percentage loss in that case. Suppose we tabulate observed values and losses in a table, it becomes very clear. On the left side, the mean percentage loss is 11.11% and on the left side it is 16.67%, not at all near 100%. So mean percentage loss is a keyword. It is not the phrase that I have invented. It's given in Gazette 2018 and used in Form A in page 107 and Form B in page 109. You have to remember this keyword, mean percentage loss. The number of directions in a joint depends on each joint. In this example, we tested AROM of hip which has 6 directions. In case of knee, it is 2 directions. In case of ankle and foot, we have 7 directions. That too after excluding movements of MTP and IP joints. In case of foot and ankle, for example, MTP joint and IP joint also should be included. But in Gazette, there are some errors. For example, in this table, you can see MTP extension is 0 degree mentioned for toes and IP joint extension is 0 degree, we know that. But MTP joint extension, if you look at your foot, you can find out 60 degree of extension is present in MTP joint of all toes, at least in great toe. And the range of movement decreases from great toe to smaller toes in a gradient. They are difficult to measure also. So how do you go about such situations? You make your own table or compare with the opposite side. If the toes are affected, you compare with the opposite side. Next, let us examine the patient again regarding the loss of muscle power. On examination, this patient was found to be having grade 3 power in both hip extensors and grade 4 power in hip abductors on the left side. How to proceed? Let us use a table again to solve it. Let us tabulate the examination findings in the table. Let us directly calculate the percentage loss and then mean percentage loss. He has 2 out of 5 or 40% loss of power of extensors on both sides and 1 out of 5 or 20% loss in abductors on the left side. So mean percentage loss is 6.67% on right and 10% on left side, because we divided the total by 6 as there are 6 groups of muscles in hip. Of course, the groups of muscles change from joint to joint. To summarize quickly, in the first stage we measured AROM clinically. The units were in degrees, then we converted that into percentages, and then we used the concept of mean percentage loss. In the second stage or part, we measured the power in grades and converted that losses to percentages, and mean percentage loss was obtained by dividing all the values by 6, because there are 6 groups of muscles in hip joint. Now let us see the second process of summarization of functional loss. The second process is to incorporate area-wise or division-wise weightage. In most of the cases, just the simple processing of conversion of values and calculation of mean percentage loss is not enough, because we have complex functions in each limb spread over different regions. We need complex rules to deal with that. To understand the next process, let us take a theoretical example of 100% functional loss without any complications. Note that in this case of 100% functional loss, the formula D is equal to I plus C becomes D is equal to I plus 0. Note that I is in lowercase, that is processed functional loss. Let us call the 100% loss of function in this case as impairment A100. We use the capital A to represent the functional loss. Whole of this 100% is never taken for final disability. We perform mathematical operations on this value and take only 90% of it for disability. We have discussed that already. Or simply multiply the mean percentage functional loss by 0.9. We have discussed this also before. Now I am giving more details. This process is called weightage. Weightage word means the importance given to the numerical value in that context. Please note, I have not created this word weightage. Weighing and weightage are the terms used in Gazette and manual in both upper and lower limb sections at many places. It simply means how much numerical importance is to be given to that set of value. The value you get is called weighted summary value of functional loss. Let us mark it with the lowercase a as shown in this slide. You can see that the uppercase A100 became lowercase a90. There is another way of explaining this concept. Imagine a farmer is preparing fruit pulp. He has freshly harvested some watery fruits. He got his fruits tested, and the report says that his fruits have high quality fruit solids, 1/3 by weight or 33.33% by weight. Before pulping the fruit, he weighs the harvest and finds it is 100 kg. His pulper machine can handle only 90 kgs of fruit at a time. The factory which buys fruit pulp from him also wants fruit pulp in lots of 90 kgs only. So he removes 10 kgs fruit from the lot, and after pulping he sends it to the factory in a large plastic bag, on which he writes fruit pulp net weight 90 kg and contents 30 kg fruit solids. In the factory they mix sugar powder as preservative to make it to 100 kg and put it in smaller tins which can hold 1 kg each and send to packing department for sealing and labeling. The label looks like this: fresh fruit pulp, net weight 1 kg, contents fruit solids 30%, sugar 10%, natural watery base QS. Here what the farmer does is weighing of the percentages. He has converted the percentage into a ratio. Because of weightage or limitation to 90% or 90 kg, 33.33% becomes a ratio of 30 by 90. Here on the bag he has mentioned it as 30 kg. Actually it is 30 kg out of 90 kg. Still the solids are in the same ratio of 33.33% because pulping has not changed it. However, in the tinned pulp with 10% added sugar, the ratio of fruit solids gets reduced to 30% by weight. Suppose the factory makes one more no added sugar variety and sells 500-gram tins. You can guess what happens. The label would be like this: fresh fruit pulp, no added sugar, net weight 500 grams, contains fruit solids 33%. See, here it is different. Earlier it was showing fruit solids 30%, now it is showing 33%. Because sugar is not added, the percentage of fruit solids has not changed and it remains at 33.33%. Similarly, if impairment is 90%, after weightage it becomes 81%. If the impairment is 50%, after weightage it becomes 45%. These resulting values are called weighted summary value of the impairment. Why do we take only 90%? That also we have discussed. That is because the last 10% of impairment supposedly will not cause any more disability, and you have to reserve that much place for complications. If a person has 100% functional loss, only if there are 10% complications, the person can have disability of 100%. If he doesn't have complications, he will have a disability of only 90% in spite of having 100% functional loss. This is also important. Finally, whole of functional loss is never taken, only 90% of it is taken. In every case it happens like this. Functional loss or impairment gets 90% weighted and it is called weighted summary value of functional loss. As there are no complications mentioned in this present case, the calculated impairment you get becomes the disability. Practically the storyline is slightly different. Instead of applying 90% at the end of the section, some part of this 90% is applied at the level of each joint separately and the values are added at the end of the section. Each joint in any limb has different weightage according to perceived importance given in Gazette 2018. For example, in case of hip it is presently 35% and knee 35% and ankle 20%. Totally the value will be 90%. Let us tabulate such a case and see the result. If AROM of hip is lost fully, then only 35% of it is taken during calculation. You can see that in this slide. Let us go back to our previous case. In that case we had bilateral hip extension loss of 66% and on the left side in addition the patient had 33% loss of abduction. You can see in this following image, mean percentage loss of hip was 11% on the right and 16.6% on the left side. After 35% weightage, the value of hip became 3.89 on the right and 5.83 on the left side. Similarly, regarding the loss of strength of hip, on the right side we got 2.33% and on the left side we got 3.5%. So the initial huge figures of 66%, 33% and 40% after step-by-step processing became small values of 3.89, 2.33, 3.5 etc. There is another very important concept to understand at this stage. It is the concept of maximum value or total value or maximum weightage of divisions and components. Let us see these statements in Gazette. The first sentence says the value of maximum AROM in ARM component is 90%. What is the general meaning of these statements? It means that if the division or component is fully affected or full functional loss has occurred in that division or component, the maximum summary functional loss one can attribute to that division or component is 90%. It is easy to understand this concept with examples. Let us check the concept of AROM in the arm component of upper limb according to page number 67, appendix 2, form A, page number 108 and 109. Let us see if full AROM of arm component is lost, what is the total value you will get. New Gazette says it should be 20 plus 20 plus 10 plus 40% in shoulder, elbow, wrist and hand. For the sake of simplicity, let us see the effect in shoulder, elbow and wrist in the first stage. Total value is 20 plus 20 plus 10 is equal to 50%. Here all AROM of shoulder, elbow, wrist and hand on the right are set to 0. In this slide I am not showing the hand values, that we will come to it later. Percentage losses calculated for each direction of movement. Mean percentage loss is calculated at each of the joints. Total value we got for shoulder, elbow and wrist together is 50%. Step 2. Let us consider AROM of hand. It is newly added in the Gazette 2018. If 100% is lost on right side, it should produce 40% of summary functional value. How do we check AROM of hand? By this time, you must be having some ideas. First, percentage losses calculated for each direction of the movement in each ray of the hand. Mean percentage loss is calculated for each ray of the hand separately. Then a ray-wise weightage is applied. These weighted values were added. For example, in case of thumb, loss of AROM is calculated as below. Thumb CMC joint, thumb MCP joint and thumb IP joint. All these normal values are given in Gazette. Finally, same method was used for other rays. Index finger, middle finger, ring finger and little finger. These weighted values were added. Lot of calculations were done here. I used a ray-wise weightage of 30 by 55 for thumb, 15 by 55 for index, 5 by 55 for middle finger and so on. This ray-wise hand weightage are based on table 5.2 upper limb amputation number 10 and number 13, page number 75, section C. The total percentage loss in hand we got is 100%. Then 40% weightage was applied to this functional loss. Here is the result. Previously we had total of 50% for shoulder, elbow and wrist together. Now we have 40% for hand. Finally it is 90% for whole of the arm component. Very interesting. Gazette is right till now. Let us check the concept in coordinated activities of upper limb according to Appendix 2 Form A, page number 108 and 109. Each coordinated activity has a maximum value of 9% and there are 10 such activities. The values are already weighted to 9%. That was easy test. Passed again. Let us check the muscle strength division in arm component. Here also the maximum value we got is 90%. Then let us check this concept of 90% value in case of hand component. According to Appendix 2 Form A, page number 108, 109, we got 90% again. Here the values are already weighted and grouped in 3 divisions in percentages. That was quite easy. Again we got 90%. Then let us go to the mobility component of lower limb, which has 2 divisions, AROM division and muscle strength division. Let us check AROM division of the lower limb. Let us tabulate the movement loss in a table as given in Appendix 2 Form B, page number 109. Here is the result. Hip, knee and ankle were given weightage of 35, 35 and 20% respectively, and what you can see is the maximum value of mobility component is 90%. Now we are left with muscle strength division of the mobility component. Let us check if we get maximum value 90% here also. Yes, we got 90% at the end. Finally, at the end we have got total value of stability component 90%. We check that it is again, we have Gazette has 9 stability related activities of 10 points each, and because they are already weighted and they are designed in such a way, you will get 90% if all the stability related activities are 0. Finally, Gazette is right. Now we have seen that each of the component has maximum value of 90%. In upper limb we have arm and hand components, both have maximum value of 90%. In each limbs we have divisions in the first components and each of these divisions has a maximum value of 90%. Now comes a fresh doubt. In upper limb, for example, the arm component has 3 divisions and according to Gazette all the divisions have maximum value of 90%. If upper limb is totally flail, all these 3 divisions will be 90%. Then what is the final value for arm component? Is it going to be 270%, then reduce it to 100%, or what is going to happen? Let us look at this situation also. Such situation requires different processing of functional loss. This chart shows that medical disability is multiplanar. Impairments occur in many categories of dimensions. In other words, there are so many physical functions in locomotor system, they can be arranged in many categories or groups. In the case of severest loss, all the functions will be lost to the extent of 100% and after weightage become 90%. However, In medium disability, the loss of function in various categories is not strictly proportional. Let us take a theoretical example of a progressive loss of muscle strength in an experiment. Let us plot the 90% values in a graph. When you plot the loss of muscle strength, it is almost straight. If you plot the loss of AROM at the same stages, it looks like this. It's in blue color. At all stages of loss of muscle strength, you can see that there is more loss of AROM. The resultant disability at all stages should be more than that of AROM. So the resultant disability also will be in the form of a curve. It cannot be a straight line. Here, simple addition or averaging will not help us to sum up the values correctly. It will just flatten the resultant value. Let us take one example. Imagine that a victim has 44.44% loss of AROM and 33.33% loss of muscle strength. How much is going to be the resultant disability? First, we have to reduce the values in each dimension to 90% of the original values by weightage. It will result in values of 40% and 30%. After this, we can check simple addition. That will result in 70%. In a case of 40% and 30% losses, we simply cannot give a disability of 70%. That appears too high. But simple addition and averaging also will not help. That will result in 35%. That value appears too less. These values are from different category or dimensions altogether. That is one more reason for not adding or averaging these values in a simple manner. Actually, till now, we were dealing with functional loss in only one theoretical dimension to find the mathematical relations in a simple manner. But practically in most of the victims with locomotor disability, the functional loss is complex and spread in many categories. How to deal with this problem of multidimensional functional loss? Gazette has given one more or third type of processing of the functional losses to solve this part of the problem. Speaking generally, orthopedics is like a long sea journey. You have many boats and many maps at your disposal. Arthroplasty, trauma and surgical treatment, trauma and conservative treatment, Elizaro, pediatric orthopedics, hand surgery, foot and ankle surgery. So many boats. You can choose your boat. You can jump from one boat to another during your long orthopedic journey. Single patient also may need more than one method of treatment. Assessment of disability is a very short part of this long journey. Many of us may not take part at all in this leg of the journey, but legally you are required to know that part of the orthopedics also. The manual and gazette are like notes handed to students. They are concise or short forms, and you have few teachers. I was fortunate to attend a course organized by Hubli Dharwad Ortho Association with KOA in 2010 in Hubli. Another gazette was published in 2018 with some important changes, but we have to move on with our journey. Let us move further on this exciting short part of the orthopedic journey. We are using mathematical boat fueled by logic and designed by gazette. You are permitted to use the boat, but only in legally correct and appropriate manner. You can try to understand the logic, but you cannot change the design. Here I am, trying my best to explain some logic. This document is mainly about the design of the process. You should be careful. Wrong process may get you stuck. Now we are going to study the third process of handling functional loss. This third process is combining more than one set of summary functional loss. Till now, we have seen about conversion of values to percentages, then percentages to mean percentage loss, joint or area wise weightages, and direct addition of values at various stages. That process holds good if there is only one set of impairment or functional loss, or you have only one component, or you have only one division affected. However, in almost all cases of locomotor disability, more than one set of function is lost. Most of the times the involved component or divisions are affected differently. For example, in lower limb both the AROM and muscle strength divisions are affected in most cases. In case of upper limb, sometimes in the same limb both the arm and hand components are affected. In lower limb, almost always both the mobility and stability components are affected. Each of these sections can have a maximum value of 90%. Then how to get the final value? Or in other words, if the disability is due to combination of two or more sets of impairments, how to go about it? How to add or combine them? Then the goal would be How to find effective sum of impairment of two sets of loss of function. I am very thankful to Deepak, my son, who is BTech CS from IIT Dharwad, for demonstrating the maths behind this part of the puzzle over a single dinner. Let us consider the locomotor system in a 100% normal man or 100% abled man. There are 5 distinct parts in the locomotor system with maximum value of 100% each. Therefore, in this schematic functional picture of normal locomotor system, each of the rectangle has a value of 100%. This appearance of the locomotor system has been imagined from the statement in the preface of NIOH manual of 2001, which says each functional part in itself is 100%. We will come to this statement later. Till that time, let us consider one fully abled right lower limb of this normal person. For the purpose of easy understanding, let us consider it as a rectangle of 100 units of activities. Similarly, you can also consider other limbs, spine, as also having the value of 100%. Suppose all the ability is lost in that right lower limb, then what is the impairment and functional loss? Both the impairment and functional loss will be 100%. Out of this 100% impairment, 10% can be due to complications and 90% of impairment is due to weighted functional loss of 90%. Here, the number of dimensions of functional loss is immaterial. As PPI is 100%, losses in all dimensions also will be 100%. Functional losses in all dimensions fall on each other to overlap into a single dimension. Let us keep only the boundaries and remove the filling colors. Please have a look at the orange boundary of weighted functional loss. All values or dimensions of functional loss have to play within this boundary of 90 units. The effective functional loss in all the dimensions together cannot be more than this 90 units. If one functional loss has occupied some area in the boundary, the area available for the next loss gets diminished. If the first functional loss gets larger, the remaining area becomes smaller. The additional disability can affect only the existing or remaining ability of the person. This is very important statement. Let us consider a person with PPI with functional loss in AROM and muscle strength divisions in lower limb. We saw this same problem just a few minutes back. Let us call those values as lowercase a and lowercase b. Here in this example, lowercase a is 40 and lowercase b is 30. Let us see how the things are going to turn around. Let us first introduce the weighted functional loss lowercase a, which has a numerical value of 40 in the orange boundary. Before that, we have to check what is this lowercase a. Actually, it was capital A or 44.44%. When it became lowercase a after weightage, it became 40. From percentage, it was converted into a ratio of a by 90 or 40 by 90. Therefore, when a enters the orange boundary, it will occupy 40 by 90 ratio of it, and 40 by 90 of 90 units is 40. At this step, there are 3 important points to understand. Number 1, lowercase a is obtained as a ratio of 90 base. It was obtained as a out of 90, and numerically it is 40 by 90. As whole of the boundary or all 90 units are vacant, a occupies 40 by 90 units out of 90 units. Number 2, it appears as if whole of a has entered the area. Actually, it is only a by 90th of the area which has been occupied by a. As the area available itself was 90 units, it appears as if whole of A as such has entered the area. Number 3. A leaves the remaining area free. That is, it leaves 90 minus A area or 50 units free. This is also very important. Now let us introduce the weighted functional loss lowercase b in the orange boundary. It cannot take up the units occupied by A already, because A has already caused that much disabilities within the available units of ability. So B can cause loss of abilities or loss of functional units available as the remaining area. The remaining area has a numerical value of 50 in this case. Before introducing B into this boundary, we have to check what is this lowercase b. Actually, it was capital B or 33.33%, When it became lowercase b and became 30, it was converted from percentage to a ratio of b by 90 or 30 by 90. That means whenever it enters any area of abilities, it will cause that much ratio of functional loss. It all depends on how much area has been left vacant. Let us see the area which is presently free or unoccupied. It is 90 minus A units, or numerically it is 50 units. We know that additional disability can affect only the existing or remaining ability of the person. Therefore, when B enters the orange boundary with 50 unoccupied units, it can occupy only the B by 90 proportion of it. That would be 30 by 90 ratio of it. Or numerically it is 30 by 90 of 50, and you can write it as 30 by 90 into 50. Numeric value will be 16.66 units out of 50 units. So instead of whole lowercase b or 30, only 16.66 units of function is lost because of b, that in the muscle strength division. That is because instead of 90 units, only 50 units were free at this stage. Let us write the process in symbols. We write 30 by 90 as b by 90. 50 is to be written as 90 minus a. So, in the remaining area of 90 minus a, the losses in muscle strength division or lowercase b occupies b by 90 ratio of it. That is b by 90 into 90 minus a. Or you can also write that as b into 90 minus a divided by 90 units are occupied by b. At this step, there are two important points to remember. Number one, you can see the whole of lower b is never taken. Only a part of b is taken. Though 33.33% or 30 by 90 area is covered by b, it could cover only 16.66 units because the area available itself was only 50. So it appears as if only a part of b is taken. Number 2, as the value of a increases, the remaining area decreases and less of b is taken into effective impairment. This is the application of the law of diminishing marginal returns. We were interested in knowing the effective impairment. In this picture, it is the total area in the orange boundary which is occupied. Therefore, the question would be how much of total area was occupied, or how much of 90 units were occupied by A and B combined together. This is the effective functional loss or processed functional loss or resultant impairment or lowercase I. So I is equal to A plus B into 90 minus A divided by 90. This formula is called combining formula by Gazette, and I am just trying to show how it was probably derived. We can take one example from stock market to understand this principle. Let us imagine an investor who buys some shares at the market rate of 90 rupees in Jan 2019. Imagine his brokerage charges were very high and fixed at 10% on each transaction. By Jan 2020, the price comes down to 50 rupees, but the investor wants to keep the stock. Next year, that is 2021, the price of the stock starts falling further. He gives stop loss order to his broker to sell the shares if the price falls by 1/3. At what price the broker should sell the shares? Before that, we should know how does the stop loss order works. It works on the current price of the share. Here the stop loss order is set at 1/3. If the price of the stock falls below 1/3 of the value at the time of the order, the stock is sold. Here the stock price is 50 rupees at the time of giving the order, and stop loss is 1/3, and 1/3 of 50 is 16.66. If the stock price falls by 16.66 rupees, the shares are sold. Stop loss order has nothing to do with the purchase price. It depends on the current price or remaining value. However, to compare to the original purchase price of the stock or 90 rupees, this same 1/3 can also be written as 30 by 90. From the stock market, let us come back to orthopedic office. The whole idea of disability assessment depends on this combining formula. This is about finding the effective sum of two impairment values. A is higher value and B is lower or equal value. Both values should be 90% weighted summary values of loss of functions in different sets. They should be in different sets, they should be related to loss of function, and they should be 90% weighted summary values. Simply you can't take two values and combine them using combining formula. Where do we use combining formula? Combining formula is used to find effective sum of any two diverse sets of impairment or two diverse sets of loss of function where the desired maximum final value is 90%. This term is used 16 times in the Gazette of 2018. Combining formula is used to combine values of mixed disabilities within locomotor system. For example, upper limb values and lower limb values can be combined using combining formula, or between left and right upper limb you can use combining formula. To combine values of multiple disabilities, if the patient has got hearing loss and vision loss and locomotor disabilities, you can use combining formula telescopically to combine the values, and to combine functional components within single disability. For example, in upper limb combining the arm and the hand component, in lower limb combining the mobility and stability component, you can use combining formula. To combine divisions within a single functional component, for example in lower limb we have got mobility component, within the mobility component we have got divisions, AROM division and muscle strength division. To combine the divisions you can use combining formula. Let us take a look at the usage of combining formula in a day-to-day example. We previously discussed this case. It's a case of PPRP in both hips. On clinical examination, he had a 5 degree of active extension in both hips and only 30 degree of active abduction in left hip. We calculated the percentage loss and mean percentage loss and used 35% weightage to get the following values as shown in this picture. Let us see his muscle strength division. In both hips he had grade 3 power in extensors and on left side he had grade 4 power in abductors. We calculated the percentage loss and mean percentage loss and used 35% weightage to get the following values as shown in this picture. Let us say he neither had any complications nor had any stability component issues. Let us go further with this theoretical example. Here movement loss ML and strength loss SL divisions are affected on both right and left sides. To combine values of divisions you use combining formula. On the right 3.89 and 2.33 were combined, and on the left 5.83 and 3.5 were combined. Again, further down you have bilateral limb involvement. As this is a case of mixed locomotor disability or more than one limb is involved, now 6.12 and 9.10 are to be combined using combining formula as shown in this picture. However, this person had no involvement of other limbs. Final verdict is this person is disabled to the extent of 15% with respect to lower limb or with respect to locomotor system. Next example is of a flail upper limb with all the divisions in arm component having a maximum functional loss of 90% each. How to use combining formula in that case? If you have three values, you have to use the telescopic method. Arrange the values in the descending order and then use the combining formula 2 times. You can see that in spite of 90% maximum value, when we use combining formula, the values get combined to 90% only. That is by the design of the combining formula. Now we have one master formula and two expansions. The master formula is D is equal to I plus C. I is processed impairment and C is the processed complications. If you know these two formulas, you have understood the whole picture. Practically how to do it? Step 1 is to find the processed impairment. The impairment is processed in 3 steps. First is to convert the functional loss in various units to percentage functional loss, find the mean percentage functional loss, apply area-wise weightage and use combining formula to find the effective impairment. Then you have to deal with the complications. Complications are processed in 4 steps. First step is to find which additional weightages are applicable in this case. That way you will get TLC percentage. Then calculate extent of complication by finding the multiple of TLC percentage and I. Then find the allowed limit of complication ALC by finding 10% of I. Then take the lower value among EXC and ALC and add any non-negotiable additional weightage like shortening in case of lower limb to get the final additional weightage or considered complication C. Finally, add the output of step 1 and step 2 together to get the PPI or medical disability D. Just for the sake of completion, let us take 5 examples quickly. If a RTA victim has only COM, tibia and mild persistent pain but does not have any mobility or stability related functional loss, how much is the disability? Answer is he does not have disability because there is no functional loss. Second case is of a person with 1 inch shortening only and does not have any mobility or stability related functional loss. How much is the disability? Answer nil or 0 because 1 inch shortening qualifies for 4% PPI in case of 100% function loss. However, there is no function loss in this case. Victim cannot claim any PPI or disability. Next case is a RTA victim with a summary functional loss of 55% and mild persistent pain of 3%. What is the final disability? Here the allowed limit of additional weightage or ALC is 10% of 55 or that is 5.5% and the extent of complication is 3% of 55 that is 1.65. Lower value among 1.65 and 5.5 is 1.65. So the final additional weightage C is equal to 1.65%. Total PPI will be 55 plus 1.65 is equal to 56.65. There should be no confusion in such cases. If a RTA victim has 40% summary value of functional loss and there are no complication, what is the disability? Answer is simple, it is 40%. If a person has traumatic amputation of little finger through MP joint which has percentage of PPI as 2% in his dominant right hand with a neuroma, what is the disability? Answer is impairment is 2%, neuroma is 10%, dominant hand is 10%, but simply you cannot add 10 plus 10 plus 2. In the manual of 1981 and Gazette of 2001, dominant hand was part of the listed complications, but in Gazette 2018 it is mentioned as a separate complication or additional weightage. Like the separate extra point for shortening in lower limb, dominant hand has been excluded from the list of complications limited by 10% of impairment. So here PPI will be 2 plus 0.2 plus 0.2 or 2.4. If a RTA victim has 40% summary value of functional loss in lower limb and has 12% complications and shortening of 1.5 inches, what is the disability? The answer is 40 plus 4 plus 3.2, that is 47.2%. How do we come to this conclusion? In this case, calculation of the complications goes like this. We know the total eligible complication given as 12%. So 12% of I or 12% of 40, that is 4.8% is the extent of complications. The allowed limit of complications is 10% of 40% or 4%. You have to take lower of the EXC and ALC, that would be 4%. This is one part of the complications. Shortening is a separate section. Shortening of 1.5 inches in lower limb is 8%. That means in a case of full functional loss or 100% impairment, shortening causes 8% medical disability. Here functional loss is only 40%. It is not 100%. So here you have to take 8% of 40% or 3.2%. Shortening is an independent complication, so the 10% limit does not apply to it. So the processed complication would be 4 plus 3.2 or 7.2%. Thus we got 47.2%. Please note, it is not 40 plus 12 plus 8 or 60%. Some people say like that. You add all complications and add it to impairment, you will get disability. That is wrong, because complications are percentages of impairment. They are not totally independent. It is also not 40 plus 4 plus 8. See that 40 comes from impairment, you know that, and 4 comes from 10% limit, you know that. Some people add the value of shortening directly, that is 8%. So totally 40 plus 4 plus 8 is equal to 52%. That is also wrong, because the percentages given for shortening is also a complication, so it is also a percentage of impairment. Shortening, though it looks independent, it depends on the percentages of impairment. The percentages given for shortening is given for a case of 100% disability. Here functional loss is only 40%. It is not 100%. So here you have to take 8% of 40% or 3.2%. So for the shortening, here we are giving only 3.2%. There was one classic sentence in Gazette 2001 in upper limb section which we have discussed before. It said the extra point should not exceed 10% of the total arm component. However, in the new Gazette, that sentence disappeared from the upper limb section. But following sentence was introduced in the lower limb section which said that including shortening, all extra points are percentages of impairment. We can see that the 10% maximum limit did not change in both gazettes. One cannot escape this 10% in whatever approach you take. This whole principle can be called as relative percentages and relative 10% max. I support this approach. Some people started telling that extra points are given as absolute percentages with 10% cap. This is another approach and it is one more interpretation. They add eligible percentages taken from the list, compare the total directly with the maximum absolute value of 10% and then take the lowest value. They do not consider that the complications are percentages of impairment. That approach may help some patients. I do not agree with that approach. Only thing is you have to take a stand about whether to calculate eligible complications as relative to functional loss or calculate complications absolutely according to the list. I go with the rule of relative functional loss with relative 10% cap as mentioned in Gazette 2001 in upper limb section and Gazette 2018 in lower limb section. I find the rule mathematically better and logically sane approach. Finally, it's your take. Let us deliberate on these two approaches to consider complications further using 2 or 3 examples. Suppose the combined functional loss in arm and hand component is 50% in a person and the patient has malalignment which is a deep complication. It is 6%. What happens? If we take the relative percentages and relative 10% max approach, value of malalignment will be 6% of 50%, that is 3%. Finally, we will get 53%. In case of absolute approach, it is 56% as 6% is taken as absolute value. The second example is an extended version of the previous example. Suppose the combined functional loss of function in arm and hand component is 50% and patient has malalignment, infection and moderate pain, plus it happens to be the dominant hand. What happens? We calculated that we have at our disposal 10 plus 18 total complications. However, the total functional impairment is not 100%, it is 50%. So, in case of relative percentages and relative 10% max, value of all complications are added together will be 18% excluding the dominant hand. Extent of complication is 18% of 50%, that is 9%. We have to find the allowed limit of complication as 10% of 50%, that is 5%. Then take whichever is lower among 14 and 5 and we have to take 5%. Dominant hand 10% is a separate value and 10% of 50% is 5% and final PPI would be 50 plus 5 plus 5 is equal to 60%. In case of absolute percentages and absolute 10% max, we get 60%. Here you can see that both approaches have given the same result of 60% because in absolute approach 10% for dominant hand got limited by 10% maximum limit. But if we consider dominant hand as independent complication in absolute approach, we would have got 70% instead of 60%. However, in case of little finger amputation in dominant hand with neuroma, the difference is very evident. When we check in the list, we get a little finger amputation 2%, dominant hand 10%, neuroma 10%. Using the approach of absolute percentages and absolute 10% max, what we get is following: 2 plus 10% is equal to 12%. Actually, if you consider dominant hand as independent complication, it would be 2 plus 10 plus 10 is equal to 22%. That is quite insane. However, following the approach of relative percentages and relative 10% max, what we get is the following result, that is 2 plus 0.2 plus 0.2 is equal to 2.4%. Finally, it is your take. I am for relative percentages and relative 10% max. I strongly believe in Gazette 2018 which says complications are percentages of impairment. Now we are coming to the seventh of the 8 concepts in the overall picture, that is the concept of functional combination. The locomotor system is a functional combination of two sections A and B. Section A consists of number 1 upper extremity and number 2 lower extremity, and section B consists of spine. All these terms, section A, section B, number 1, number 2, are given in gazettes. If more than one part of the locomotor system is affected, the condition is called mixed involvement or mixed locomotor disability. In that case, we use combining formula to find the resultant final impairment for locomotor disability. So the phrase functional combination is very important. All the functional assessment or the measurement of the loss of functions in locomotor system is arranged in the gazette on this pattern. We will learn more about this in the next video on flowchart. Now let us discuss the last concept, the mixed locomotor involvement and multiple disability. Some people say locomotor system is broadly divided into 3 parts. Some even go to the extent of saying that it is divided in 3 equal parts. They say if a person has disability of locomotor system, you take 1/3 of disability of the limbs to apply to the whole body. According to them, if upper limb is disabled to the extent of 45%, for whole body the disability is 45 by 3 or 15%. It is absolutely wrong. It is nowhere mentioned in this gazette or manual or in previous gazettes. Locomotor system is not divided. Actually, it is the measurement of the loss of functions which is divided. The measurement process was divided for step-by-step calculation and for proper understanding. However, in a publication by NIOH in 2001, there was a statement in the preface which is quite usually interpreted wrongly. It says, in case of locomotor condition, broadly the body has been divided into upper limb, lower limb and trunk. People usually read the first sentence and stop. They do not try to read the next sentence or understand the remaining matter, which is more important and has deeper meaning than the first misleading sentence. Note the next sentence which says that each functional part itself is 100%. That clarifies that the disability you calculate for each part applies to the whole body. It is because each functional part in itself is 100% and no other part can replace it. Thus, loss of function or PPA of that part is taken as 100%. However, this statement is not there in present gazette, neither there is any preface. So simply we can neglect this. Since the process of dividing the value by 3 is not given in the present gazette or divided by 3 is irrelevant at present, simply we can neglect this. Actually, it was not given anywhere else till now. But still, for the clarification, let us continue the discussion. What was wrong with the statement? It missed the term of body or individual at the end. Let us add that phrase and read it again. Therefore, each functional part in itself is 100% and thus the loss of function or PPA of that part is taken as 100% of body or individual. Is it not giving a full and totally new meaning? And that statement also did not cover another important instruction. That is, every upper limb by itself is 100%. Similarly, every lower limb by itself is 100% and spine is also 100% by itself. Thus, there are 5 functional parts in the locomotor system, each with 100%. If more than one part is involved, what to do? Let us look in the present formula is to be used. Simple totaling and taking the mean is not to be done. Why is it so? There are 3 indirect explanations. Explanation number 1. Such a situation is described in present gazette and it says that one should use the combining formula. It is termed as mixed locomotor disability of chronic neurological diseases under section E of locomotor disability in page number 79. Why should you consider the concepts of neurological conditions while studying or describing musculoskeletal conditions? It is because of the following definition of locomotor disability in gazette. All the rules or concepts of assessment of disability are same whether the cause of disability is affliction of musculoskeletal system or nervous system or both. Actually, same form A and form B are to be used in both cases. Explanation number 2. In case of bilateral involvement, we use combining formula. It is mentioned in page number 78 and 79 under locomotor disability. Explanation number 3. If more than one system is affected, the condition is called multiple disability. For example, locomotor disability and visual impairment together in a person is called multiple disability. In multi-system involvement, we use combining formula that is given in page number 105. Finally, that means if more than one part is involved, one has to combine them using combining formula. Absolutely no question of addition and averaging. Before ending this video, let me summarize it in 3 points. Point number 1. Locomotor system consists of section A1 upper limb, section A2 lower limb and section B spine. You have to by heart this definition of locomotor disability, which is given in page number 67 of Gazette 2018. 3 situations are possible in locomotor system. Situation A. Single part involvement. Examples are one upper limb or one lower limb or only spine is involved. Remember the principle, each functional part in itself is 100%. Accordingly, we have to calculate impairment and complications for that part to find the resultant medical disability. Situation B. Bilateral involvement. Examples are both upper limbs are involved or both lower limbs are involved. We have to calculate disability for each limb separately and then use combining formula to combine the disability. Situation C. Mixed involvement. Person with locomotor system impairment may have disability in more than one part of locomotor system. For example, one limb and spine, one upper limb and one lower limb, both upper limbs and one lower limb, etc. In such combination of cases, first we have to calculate disability for each part separately. Then combine bilateral disabilities and note the values. Then arrange these mixed disabilities in the descending order. Do telescopic combining. You will get the final value for the locomotor system. It is mentioned in page number 78 under lymphedema, page number 79 under chronic neurological conditions. Point number 2. Multiple disabilities. Person with physical impairment may have disability in more than one or multiple systems. In such cases of multiple disabilities, we have to do telescopic combining to find the disability to the whole person. That is mentioned in page 105. Point number 3. If only one part or one system is affected, the disability you get in that part or system, though expressed for the given system, is the disability for the whole person, because no other system is affected or no other part or no other system can replace the affected part or system. This is mentioned in locomotor disabilities in persons with different conditions, where disability is calculated for one part or activity and is directly expressed in terms of whole body. For example, page number 81, spinal cord injuries, 84, cerebral palsy, 87, dwarfism, 88, muscular dystrophy, because each functional part in itself is 100% and thus loss of function or PPA of that part is taken as 100% of the whole body or system. Thank you very much for your patient hearing. I hope you have enjoyed this very short part in the very long journey of orthopedics.